here we have our whole team of cardiology. Dr. Shuvanan Karmakar, my colleague, is on my right hand side. I have my brother Jijo, who is assisting me, and also our technicians Niladri and Sujoy. They are also in the cath lab. So Dr. Karmakar will be discussing the case and introduce the patient to you.
So this is a 69-year-old female, hypertensive on irregular medication, married and postmenopausal, developed pain in the left arm which radiated to the chest while moving upstairs. She started having profuse sweating and shortness of breath. She was taken up to nearby hospital and given medication in suspect of cardiac chest pain. The pain got subsided, but it recurred several times in last 20 days. So ECG showed some non-specific changes. On echo, there was no RWMA with normal ejection fraction.
Next.
So this was the angiography which we did, which showed a long segment narrowing from ostial LAD to the mid part, showing a very tight lesion in the mid part, about 80% focal disease, and there is also some visible calcium on angiography. Circumflex is relatively normal with a small lesion in the distal part of the terminal, in the beginning of terminal vein. And this is the LAD, which we can show we can see the disease in the mid part and the proximal part. So can I have the RCA view?
So next. So we did, there is a RCA. This is RCA.
Okay. So RCA is also showing a discrete 90% lesion in the mid part.
So basically we thought of doing the RCA only, but then we thought that whether it is feasible to go to the LAD and see that whether it is the ischemia producing or not. Then we did the RFR to LAD. Can I go back to RFR? And that RFR shows 0.84. So it is quite significant. So we thought of going to the LAD, and we did in the meanwhile we did a IVUS, and we can you show the IVUS, please? And in the IVUS run, you can see the IVUS run. The distal LAD is okay. There is okay. Go ahead. Distal LAD is okay, and after that there is a 3 millimeter LAD, and after that you can see there is a eccentric plaque, fibrous plaque, and with tight lesion there, followed by near the ostium there is some amount of calcium, and near the ostium you will see that there is almost 180-degree plus calcium arc on the ostium of the LAD. The left main, you can see that. And after that, the left main is okay and healthy. So we thought of, we can see the angiogram also in the upper panel, and we thought of doing a rotational atherectomy to the LAD, and particularly in the LAD ostium and the proximal part, and then to put a stent across the LAD ostium to left main. So any comments about that?
That looks very reasonable. What about the diagonal? You plan to intervene there too?
No, this is, you see that this is the diagonal is less than 1.5 millimeter. I just will keep it open, that's it, flowing.
Actually, Shuvanan, you are thinking about a rota in the proximal LAD because of the calcium 180-degree arc.
Yeah, that side. Yeah.
180-degree arc calcium. Do you think that it can be just taken off by a cutting balloon without a rotablator?
Yeah, it can be done with the cutting balloon sometimes, but the cutting, you see that if
because the calcium I could see in only on 3 or 4 millimeters is 180 arc. Otherwise, it is not that significant calcium is throughout. we may be able to just
No,
get
the
away
basic.
with the cutting balloon.
Yeah, that's right. But you cannot take a chance on the ostium of the LED. You cannot take a chance on the ostium of the LED if it doesn't open. Then you need to go with the bar again, and that will make the process unnecessarily complex. So I thought of going with a
strategy is excellent.
rotational atherectomy and implobal.
No, Shuvanan, the strategy is excellent, but I'm just telling that you may be actually getting away with the cutting balloon in this case because of the calcium.
Yeah, if I do not have an access to rota, absolutely.
Okay, okay.
If I do not have an access to rota, I would have gone for a cutting balloon.
Okay.
Come
so
on.
Your strategy
So
is
we are
actually
going towards a rotational atherectomy.
Your strategy is actually
just tell me.
Shuvanan, your strategy is stenting up to the ostial LED because the LMCA is totally free of disease, right?
But you can see the angle of the this thing, angle of the LED and LMCA, which is not very conducive for going inside the to keeping the whole thing in the this thing, keeping the whole thing in the ostium. So it is better to go to the left main and.
No, your strategy, if it is going up to the left main, what will be the size of the stent you take? What will be the plan you will have? Because it is a 5 millimeter vessel in the LED.
Perfect.
LMC, and it is actually 3 or 3.25 in the proximal
No, so
LED.
yeah, perfect. No, the point is we have measured the diameter of the LED. Ostial LED, it is 3.5, so we'll take a 3.5 millimeter stent, and I'll keep it in the middle of the this thing LMCA, which is around 4.8. So I will take a 3.5 millimeter and go up to 4.5. That's it.
So you take a 3.5 millimeter stent and will go up to 4.8.
So according to the that's it. Onyx, I will take a 3.5 millimeter onyx, and it will go up to 4.5 plus. So that is my plan only.
Actually, usually what I do in this case, is, I take a 4 millimeter stent. I just go to 8 atmosphere to keep 3.6, 3.7 in the proximal LED, and this 4 stent will be inflated to a very high pressure in the LMCA part. So I just do like that and just keep the 3.5 millimeter stent proximal LED. Very high pressure and dilate open very well, and you will get a 4.5.
Is there any chance
Maybe
of dissection at the distal LED?
That is also
to avoid that, because now the Onyx can go, they say,
the
6 also, 5, 6.
You should actually clearly understand that a stent is actually not 4 or 4.5 or 3.5. These are all stents designed with the balloon. Because of the balloon, it is actually inflated to 4 and 4.5. You can take a 4 millimeter stent, because the problem is actually when you stretch a 3.5 stent into 4.5, definitely there will be a forward, the shortening will be there, no doubt about it, whatever you tell.
In that case, can we deploy that force?
No, there is also a point,
post dilate it so that we can avoid.
What is the problem in that? Actually, if you take a 4 millimeter stent and okay, Shuvanan, please. Now we are
the point is why I'm taking a 3.5. You see.
Now you are taking a microcatheter for exchanging
on the micro. I am changing the 2 rota wear.
Okay.
Yeah, that's it.
The plan is to take a 1.5 rota.
So why I am taking a 3.5? Maybe 1.75. It is 3.5. I'll take a 1.75.
1.75 rota you are going to take. Actually, this is a 7 French catheter, right?
Yeah, that's it.
7 French catheter, right?
Yes.
Okay.
Perfect. So my why I am taking 3.5 is there is another point here, that is this is a bifurcation of the left main where is the Medina, where it is Medina 0, 1, 0. Now if I take a 4 millimeter stent, there may be slight pinching of the circumflex which I do not want. I'll rather go for a pot which will hide. Yeah, give me 1.75 bar. So basically, I will take a 3.5 and go up to 4.5. That is my this thing plan, and in that way I can save the circumflex, and I can finish the case with one stent at least. So this is a 1.75 bar, and we will go only the proximal part of the LAD. I won't go very distally. Only the ostium I want to clear it. That's it. I will not go distally inside the LAD.
Do you think in a rotablator, if you do a rota in a severely fibrotic lesion, it will damage the vessel or not?
I couldn't get you.
Do you think a rotablator in a severely
Hello?
fibrotic lesion will damage the vessel?
Huh?
I don't think it is. It will not.
Not at all. Not at all.
Yeah, yeah.
Not at all.
Even if you go a little
Rather, when
down,
rota
nothing will happen.
came, nothing will happen. Yes.
So can you explain again the strategy
I know
now
that.
for the audience? So you wanna rotablate the proximal part of the LAD, but you wanna not rotablate the mid section of the LAD, correct?
Yeah, that's it.
Okay.
No, there is not much of calcium there, which I can open with a balloon, perhaps. And this is not a very large vessel, that is 3 millimeter. Unnecessarily, I do not want to ablate more. My job will be just to modify the plaque, in any case. So I would go only for the ostium of the.
Shuvanan, then why we are actually only the
Yeah,
plaque
just tell me.
modification is your plan? Why do you take a 1.75 instead of 1? Why don't you take 1.5 instead of 1.75?
It is just. No, I take only 0.5, you know. The ratio is 0.5, but to artery ratio.
Vessel size is 3.5 and the vessel.
So before going into the things,
Off course.
yeah, ostium is 3.75.
Checking.
Just no. We are testing that. Okay. This is 1,50,000 RPM. Okay, down. We are going towards the vessel
दौड़ दी.
with the rota bar.
जब lax हो जाएगा तब पकड़ना.
So this is slowly going.
Wait, sir. No.
Turn out to push.
Your wire is coming back.
That's it.
Wait, correct to the
Yeah, no problem. Put the dynaglide on.
Dynaglide on.
Press.
Rota.
Press. Rota. Okay, that's it. Come on.
Very good. Off course
Wire
दाना.
clip. Off
Wire clip.
dynaglide.
Okay, Saurav.
Okay.
Okay. Ready.
Tablet. Okay, off. I'll go down a little bit.
You actually went up to 160,000 RPM.
Yes, that there was a 10 dot drop, so it came out. So this is not a very
Where?
smooth lesion. Again, go to dynaglide again.
Dynaglide on.
Pull karo. ये करो. Okay, that's it. So.
आगे भीतर जाओ. Okay.
चलो जाओ कौन?
Ready?
हाँ. I think we'll go to up to this. Okay. I'll go up to this. Just picture. We have just ablated the tightest portion of the ostium. Now, and we'll just take a picture. Take a picture.
Yes.
Okay, take a picture.
Ready? Yes.
Perfect. Chalo, come on. So our job is done. We just ablated the ostium. Now we will come out with the rota and
So the mid part of the LED is actually not calcified lesion because it is severely fibrotic. You just avoided it.
okay. So I will not go there. There's no point going there with a larger bar. There may be dissection and also
your wire is coming out.
where is there and I don't require the wire. Okay, I think I don't require the wire anymore because I'll just put a BMW there. Okay, give me a BMW. Give me 2 BMWs. First one. Okay.
Actually, whenever there is a virus coming out, you can use a Dynaglide and just push the wire down. There is no big issues inside.
I showed you that how to do that.
Yeah.
It's not a very difficult job. Just go to Dynaglide and push the wire in, it will go in.
These are all actually, it's a training program,
So
so you have to tell each and every
Now,
step.
Right. But I know that Pratap is there. He will fill up the blanks. So now we will go to the LED and LCX. No, I'll go to that. No, it has gone into the diagonal, right?
I usually keep both rotor wire and the wire together because it will may behave like a small cutting balloon.
I know. A cutting
same.
balloon, but I'll be using a scoring balloon. There is no point. It will be same at least. Okay, just take a picture where I am now.
What are LED the name? We will put it.
Okay, that's it.
Now, put it. Take.
It's going into a small branch again. Okay,
Yeah, right.
we are in the right place. Okay, give me another where I'll go to the circumflex.
Shuvanan, actually, Shuvanan Roy, we may switch over to the next lab for another 20 minutes and we will come back again. But we will see
Okay,
for
okay,
1 or
okay.
2 minutes more.
Okay.
Then we may switch over to the other lab and then come back after 20 minutes. By that time, I think we will be
no
having
problem.
excellent result with you.
I'll finish probably.
So you did a
Thank you very much.
rota with 1.75, 160,000, never went to the mid part, and
Yeah.
your major work is done. Now you've taken a wire in there. With you have removed the rota wire also, right?
And I'll just dilate it with the balloon.
Okay.
Yeah.
Okay.
I'll take a balloon, maybe a scoring balloon, and just cut the things down. Okay.
I think this is a very important step. You have to have,
so
whenever you do an LED or LMC LED, you should keep a wire into the circumflex to have a protection. That's all. Because it's very, very important.
Always there is if you do a provisional, it is always jail the wire to them to the
That's a very
right
important,
place.
very important step.
Yeah, put a yeah. Now give me a maybe a 2.5 millimeter 2.5 millimeter scoring for the distal this thing.
Will you do an IVUS after doing a pre-dilatation and assess again the ostium of the LED to understand what is the lumen area before putting the stent? Or is it required or not? That's only
Yes,
one.
absolutely. So I think after doing the balloon dilatation, I'll put an IVUS, and I'll show you when you will come back. I'll show you that. Okay.
No, usually, actually, Shuvanan, whenever in this case, I
Because
will
for
do a pre-dilatation with a 3 millimeter balloon, and again I will see the vessel before putting the stent. May see a better, more dilated vessel.
No, absolutely. I'm going to the distal artery.
Yeah.
So I'm going to the distal, which is not 3. That is 2.75. So I'm taking a 2.5 scoring balloon for the distal artery. Then I'll come back with a 3 millimeter balloon.
100%.
Yeah, that's it.
I think we can switch over to the Artemis lab to New Delhi because next 40 minutes
Go ahead. No
Okay,
problem.
Shuvanan.
Okay.
We'll see you again after
Okay.
40 minutes.
Thank you.
Okay.
Thank you.
Now we dilated with a balloon. I told you that a scoring balloon and we have dilated. And after that, we came up to the ostium again, dilated with a 3 millimeter balloon. And then we went with stents. It is 2.75 into 26 onyx. It has opened nicely. And then we put another stent. Show the stent only, huh? Quick.
What is the size of the stent? Size of the stent?
The stents up. There is 3.5 into 30 onyx.
Okay.
So we open that. This is the after the stenting. Then we cross the wire, transferred into the circumflex. No. We just did a pot and then cross that whole thing. See the pot. This is a 4.5 millimeter balloon. 4.5 into 8. You just see that the distal marker is just at the carina. And then next. Then we inflated the balloon. And next. And then this is the final. See that after the pot, we just went with the last start, and it went into the circumflex easily. So again we post-dilated with a 3 millimeter balloon and a 3.5 millimeter balloon from the ostium to the whole LED. And then we are doing the final IVUS run. This is the final result. Circumflex is excellent. So we'll do the IVUS and come out. This is one single stent crossover. So I had no intention to put one stent in the circumflex.
Yeah. Now you are doing an IVUS to understand. IVUS did you do an IVUS to the circumflex?
I'll do that. Don't worry.
Okay.
And did you open the struts to the 6, the circumflex?
No, I did not because I believe that if the circumflex is not involved, I won't do anything. If it is slightly pinched, maybe 30%, then I would have gone for this. Otherwise, you can go with a RFR or FFR word to see that whether there is any this thing. Otherwise, there is no point going to through the starts and dilate that.
It's okay. It's okay. Many people actually just keep one of the strut open because since you did a very good pot with a 4.5 millimeter balloon, there is no requirement because the struts are well opened up.
Yeah, right. So this is the distal LED. The starts are coming now. It's well opposed. You can see.
2.5, 2.7. Yeah. 2.1 to 2.2. Even with a 3.5 millimeter post dilatation, you got only 2.5.
Yeah, maybe that. But there is there is slight muscle bridge there.
Yeah.
I never went. I expected that would be otherwise the stent would have been crushed.
Yeah. Usually that is a strategy. Even if you take a 3 millimeter balloon stent, when you do an IVUS, you see maximum 2.5 with the same stent, and if you even post dilated 3.5, you may get 3. That's all. Now there is some under expansion there. That part.
Yes, that's right.
This is the part of LMC, right?
Yeah. So this is one part. Now I go to the.
Shuvanan, can you tell what is the ostial part of this LED?
Area,
ostial LED. What is the area you achieved? What is the? Can you show again? IVUS.
Yeah. Just I'll show you. Don't worry. Ostial LED, Bhushan, please.
Ostial LED. LMCs definitely you have require 5 millimeter balloon.
Just a minute. I'll do that, don't worry.
6.7. 7.
Area wise, it's good. 6.7 millimeter, 5, 6, 7, 8.
Now what is your strategy? You are going to take a 5 millimeter
How
balloon
much is
to
the area?
post-dilate?
I don't see any justification. They see the area, it is 12.46.
No. I'm just telling you about LMCA part.
Yeah, LMCA. The area is 12.46.
No, no. Show this
Huh?
is LED ostium.
LED
Show us
ostium,
the-
okay.
show
Go
us
to
the
the
LMCA.
LMCA, please. Go to the LMCA. What is the area?
Yes.
It's 13.6. What else?
Actually, no.
14. No. Actually, it is 14.39.
So area, if the area is good, even if the stent is hanging, it is very
So,
good. Huh?
Yeah, it's perfect. And also, I won't go, by, it is enough, I think. If I can achieve the area, I think it is enough.
No, under expanded stent.
And moreover, a 3.5 stent, 3.5 stent cannot be pushed to 5 millimeter. There
This
is
is
a
the-
chance of disruption of the polymer
This
as
is
well
the-
as
see-
the stent fracture. So I won't go there.
Shuvanan, that is the only thing I wanted to explain again. I was telling you in the first point, if I would have taken a 4 millimeter stent, I will go little under expansion, the initial expansion, then I will take the 4 millimeter in the proximal part of the LMCA, go up to 4.5 or 5 millimeter and dilate to a high pressure so that I will get an excellent area in the LMCA. This is the strategy I follow. I really don't know how many people follow that, but I'm just telling you, this is one area. I was actually done a lot of cases, and by the time I understood, this is not the strategy. At 3.5 millimeter, how can you go up to 5? It is difficult. So I always take a 4 millimeter stent.
No, I know that. I do no. Point is, I go for the areas, not in the diameters. You see, so basically 3.5. When I chosen 3.5, I knew that if I can go up to 4.5 and the ADAPT DES study, you can see that if you can achieve the 80% of the diameters, you are done.
Yeah,
You
okay,
never push the
okay.
stent too much.
Thanks.
There will be. This is my strategy. See, I follow the ADAPT DES strategy. That I achieve 80% of the this thing with the second generation DES, and I in my cases series, I know that my restenosis rate and MACE is less than
Correct.
3%.
Shuvanan, what you are telling is correct. One comment from the audience.
Dr. Shuvanan, I have only one thing to tell you.
Yeah,
When you were
that's
running that IVAS run,
Yeah.
the stunt is under-expanded at one point. It's not mal-opposed. It's like, it's a mal-opposed stunt, sorry, not under-expanded. So I think even if you have got a minimal luminal area of 14, I still feel you should go ahead and post-dilate with 5. You're
Where is
using
the-
Onyx, right? You're using Onyx, right? The
No,
stunt you have
Is
used
that-
in
yeah,
LED,
Onyx 3.5 milligram.
you can stretch up to
No.
5
Point
easily,
is,
no?
there is no malapposition. You can see this.
Yeah.
No. You cannot go up to 5. In a 3.5 millimeter stent, you go at least up to 4.5, not more than that.
No, but it is an
In
open
that
cell
case,
design
they
stent.
do
I
not
think
guarantee
can-
you for the stent fractures and all.
Okay, it's okay.
No, that's true, but the official, this thing is not more than
Don't you think you will
4.5.
come up later on with an ISR because it's already an under-expanded and mal-opposed stent? Don't you think?
I have never seen that. I have a series of, more than 200 left men. And all are
No,
logged
Ramesh,
after, all are logged and
Shuvanan,
all
Shuvanan,
angioed after 1 year.
it's a
less than
wonderful.
3%.
No, it's a wonderful result, and actually we have some doubts regarding these things. One more comment from the audience. See, if I do this intervention, actually my strategy will be little different, but Shuvanan is an excellent operator. I'm just two points I wanted to tell you. I will try to post-dilate with a 5 millimeter balloon. I'll just try. I think Dr. Hiramat wanted to make a comment.
Okay.
Good strategy too.
Connected.
Shuvanan, it is a wonderful work, and we are, because of the lack of time, we are just switching over to the other lab. It's an excellent super. Please give a clap for Shuvanan. Thank you. Excellent, Shuvanan.
Thank you very much.
We are switching over to the next lab, Dr. Sandoz.